Hi guys. I don't know if this is working, and I couldn't figure out how to share it to the Facebook group, so I don't I don't know. I'm gonna have to figure that out. But I figured I could save this and then somehow upload it to YouTube and then have it. I'm gonna need some tech help. So, okay. I'm gonna go over oral tumors. So I shared the video with who I could. I'm doing it on a Facebook portal, so I don't know how all this works. I'm gonna have to just play with it. But we're gonna go over Chapter 53, oral tumors. This is a review for our exam on the 10th. And I'm going to talk about leukoplakia. So we'll just kind of run through what is in the chapter that we went over in lecture. So leukoplakia is those are going to be the oral cancers that are thick white patches. They can't be scraped off, and that's how you'll know the difference between those and candida, which is the oral thrush. Are usually raised and rounded, and most of them are benign. If it is cancerous, it's generally going to be on the lips or the tongue. So, uh, causes of leukoplakia are going to be poor fitting dentures, cheek biting, broken teeth, misaligned teeth, that sort of thing. You're going to see hairy leukoplakia in HIV patients mostly, and then patients who use tobacco products or dip, they usually call that a smoker's patch. It is 2 times more popular in men. And then erythroplakia, the red velvety lesions, those are generally considered precancerous and usually biopsied, but they are generally on the floor of the mouth, the tongue, palate, and mandibular mucosa. General mouth or oral care, patients should see a dentist twice a year, every 6 months. Most of us go get our teeth cleaned. Prevention, you want to avoid sun exposure, tobacco, and they need to decrease their alcohol intake. They can brush and floss daily, twice a day, at least. Have a really nutritious diet, and then they should avoid mouthwashes with alcohol as the base product. So also make sure their dentures are nicely fitted. 90% of oral cancers are squamous cell carcinomas. They're usually red, raised, eroded patches that don't heal within 2 weeks. So they might feel like a lump or a thick uh, part of their tissue, and then it should be assessed by their primary care or a dentist. And then if they feel like it's not looking so good, they'll refer them over to oncology. Definitely want to look over their lips, tongue, buccal mucosa, and their oropharynx. I believe that's where most oral cancers are going to be found. Increased risk of oral cancer if they're a smoker, of course, if they're an alcoholic, and if they're over 40 years old. There also seems to be a connection between HPV and oral cancer. Also, basal cell carcinoma is generally going to appear on the lips. That was that photo she showed us with the lesion ulcer on their lips with like the pearly border. And then also Kaposi sarcoma. That's a malignant lesion in the blood vessels. It's usually raised, purplish nodule, painless black. And Kaposi sarcoma is usually you're going to see the lesions on the hard palate, which is on the top of the mouth, but it can also be on the tongues, gums, and tonsils. So keep a good eye on your AIDS patients for that too. And then also for assessment, we went over looking at periodontal disease, if they have any difficulty chewing or swallowing, if they've had any unintended weight loss. Also, make sure your pen light has a good battery in it. So you're going to have to use that a little bit here. And then we also discussed the dentist having the oral CDX, where they can brush the lesion, and they can do that on routine dental exam to see if they have precancerous cells. They also have last time I went to the dentist, they had a UV light and they were able to check for oral cancer with that. I guess that's something newer, but I thought that was really neat. The gold standard for oral cancer screening, if they feel like they see a precancerous lesion, is to biopsy. So they can also do CT and MRI to see exactly where it is and if it's spread to any of the lymph nodes, how thick it is too. Oral tumors, we really want to place special interest in their airway. They can be treated with surgery, chemo, or radiation. If they're going to do 2 or 3 of the treatments together, it's considered a multimodal therapy. And just remember that in class you mentioned that chemo is never used by itself for these patients. The priority, of course, again, is their airway. Things that we want to pay special attention to as nurses, we want to prevent aspiration. So you're going to thicken their fluids, and also make sure you have suction equipment nearby. We want to ensure that they have proper air exchange, auscultate their lungs, promote deep breathing, listen for any stridor, make sure the patient is in semi-Fowler's position or high Fowler's. Push fluids, that's not in our book, that's written down in pencil, so I know one of the professors said it. Also, oral hygiene, you want to establish a really good routine for them, and then check their gag reflex, their ability to swallow, and then they may need to have a swallow study and actually visit with the speech therapist as well. So we always want to loop those therapists in. Let's see. That was... all from our book. So, and then my notes written out in the book. Also, we want to check their platelets. If their platelets are under 40,000, then we want to switch them to an ultrasoft chemo brush. And then we should not use the toothlets, the little foam brushes, to do oral care on these patients. It dries out their mucosa. Also, don't use commercial mouthwash with them. They need to be using a special mouthwash. Depending on what their doctor orders, they may order like magic mouthwash or something that's a saline rinse or a sodium bicarb rinse. Just depends on the patient. So with radiation, there's 2 different kinds that they can do. They can do an external beam, or they can do interstitial implantation. So radiation is usually going to be done 5 times a week for 6 to 9 weeks, lasts 10 to 15 minutes per treatment, and it's also, the interstitial implantation is called brachytherapy. I'm not sure how you want to pronounce that, but brachy or brachy. And then for the interstitial implantation, they are usually hospitalized and put on radiation transmission precautions while the materials are active in their body. So they cannot have any visitors who are under 18 or any visitors who are pregnant. They may have visitors for up to 30 minutes, and those people are asked to stand in a specific part of the room so that they're not exposed to the radiation. You should also discuss with your patient the possibility that they need a tracheostomy. And there is also actually a targeted treatment for growth factors. Cetuximab is one of the drugs that's mentioned in our book, but I guess just know that that is an option for some patients. For some patients, if the lesions are small enough, they can be removed on an outpatient basis with a local. And then if they have to do cryotherapy or photodynamic therapy, then it's possible that they could go under anesthesia but still be seen on an outpatient basis. It really just depends on how big and the size and location of the oral tumor. So if it's stage 3 or 4, you really want to assess the psychosocial aspects of disfigurement and loss of function, especially if they have to do a radical procedure where they have to take out the jaw, parts of the jaw, or any of the muscles here, the sternocleidomastoid, or that can really affect someone. And then we just want to make sure pre-op that we document the patient's understanding of the procedure, the rationale for the surgery, and then also any planned interventions. So you want to teach patients, especially with chemo, about antiemetics, how they're going to feel throughout the treatment. Also, that they're immune compromised. So you need to teach them about being immune compromised. They shouldn't go in crowded areas. Anybody who comes to see them shouldn't be sick. And if they think they are going to, get sick, they need to wear a mask, and they need to eat really healthy. And also, when they come out of any of these procedures, even the small lesions that are removed, they may have to be on a liquid diet for a day or however long, and then advance until tolerated for more chewy food. The different types of procedures that we have listed in our book, we have a glossectomy, which is where the tongue is removed. That sounds really horrible. But they can replace the tongue. I actually had a client with this when I worked at the disability office. They took out the patient's tongue and they used a muscle from his chest. This is so crazy. So this guy had like live tissue from his chest connected to his mouth. So where they severed his tongue, they attached a muscle from here, and he had to stay like that for several weeks until everything healed. And he was on a G-tube, and we were applying for a Social Security disability for him, and all we had to do was basically send a photo of him to the judge, because you can't really work when you're set up like that. So it was really, really crazy, but really awesome, because once the procedure was finished, he had a pseudo tongue, so he could go back to living a quasi-normal life. So it's pretty cool. They can also do a partial mandibulectomy, which is where the jaw is partially or fully removed. And then a commando procedure, that's the radical one. So it's going to be a neck dissection, mandibulectomy, and an oropharyngeal resection. So pretty crazy surgery. And post-op, we want to do trach care, protect their incision from infection and mechanical damage. We want to promote nutrition. We also want to teach the patient before the surgery about the possibility of a trach, and because when they wake up from the surgery, if they're trached and they can't talk and they don't know that was a possibility, they're going to panic. So you want to predetermine a method of communication with them, whether they're writing on a little whiteboard or just answering yes and no questions, by nodding their head or by making some sort of hand gesture. When they can cough productively, then that trach can come out. So that may determine how long they have it for. We need to post-op do oral care every 4 hours, and then they'll start out on an IV, usually IV morphine, according to our book, and then move on to PO Percocet after the IV is taken out. They, depending on the patient's surgery and prognosis, they may be NPO, or they may be on nasogastric feeding. So it's important to take daily weights and make sure that we are always assessing their hydration status. You want to make sure they stay hydrated. Again, push fluids. They may need to do swallowing exercises, and then don't forget to thicken their fluids because of their risk for aspiration. Pardon me. At home, we want to make sure that they're doing proper dental care. Also teach them if they're having chemo and radiation, they're going to be very, very fatigued. So they may become deconditioned, and they may need to meet with a therapist, physical therapist, to increase their stamina. Also, they may have dysphagia and alterations in taste. The book said something about things like especially meat tasting metallic or metallic taste. And then I have chart 53-5 circled in red. So I would believe our professor said to know that chart. And that is about patient education. And I think that is pretty much it. So if anybody has anything to add, maybe put that in the comments. But that is a quick review, very quick review on oral tumors. And oh, I have one more thing checked. We want to, if they're doing a large surgical resection, I did want to mention this. They may be on oxygen therapy and have your suction equipment nearby. And then also, they need frequent monitoring of vital signs. And they need to have IV lines in place for their drug therapy and hydration. And then postoperative activity, they may be out of bed on the first day or the first postoperative day. And then they might have drains as well. So I have all of those checked. But yeah, that's it, guys. Thanks so much. You awesome. Bye.